Thanks for coming out to see us out here in Verona today. So one of the things I wanted to share with you this month is a new tool that we have. It's called video laryngoscopy. So we've actually had video laryngoscopy for quite some time. Due to some changes in the manufacturer, some supply issues, we've actually changed our tool. So we've switched to what we call an air track now. So I thought I would kind of show you that and introduce people to kind of some of the things that we do out in the field. So essentially video, as it sounds, laryngoscopy, larynx, right, is the mouth. Oscopy is a camera. So essentially it's a camera we put in the mouth for those patients who we need to what we call intubate, right? Lots of big medical terms for us here today. So if we have a patient who, the ultimate patient in cardiac arrest, patients who are not breathing, or patients who are unresponsive, or patients who we're really kind of concerned about that they're not breathing on their own, they need some assistance breathing, they might vomit and compromise their airway. So we're kind of, airway is the big thing we need to do in EMS, and making sure that people are breathing, right? Followed very quickly by having pulses, but we're going to focus on that airway today. So yeah, that's the tool I kind of wanted to share. I've got our mannequin. We're in our simulated ambulance here in Verona. I pulled out my stuff just because we always want to practice like we actually do our performance. So normally I would have on gloves, I would have on a mask. I'm not going to wear the mask so that you can actually hear what I'm doing. And then you can see it. We are up close and personal to somebody's airway. So there's lots of diseases that could potentially be spread with respirations and airway and mucous membranes in there. So normally we'd also have on a set of eyeglasses when we're doing this procedure. So that's we call our personal protective equipment. I'm going to leave it all off today just so you can see, but that's what we're normally doing. So this is our patient. He is not breathing. We've done our assessment. He's not breathing, or we can say ineffectively breathing. So we need to assist him breathing. We start off with this thing, we call it a bag valve mask. If you've ever taken a CPR class before, watched anything on TV when we breathe for somebody, we just put this over a face. We kind of pull that jaw up in there and we breathe for our patient. We can do that head tilt chin lift maybe you've seen in a video, and on our mannequin here you can actually see his chest go up and down just a little bit. So that's what we're looking for, and we're breathing once every 5 to 6 seconds. That's how a normal breathing is. Just enough air to see that chest rise and fall. So here's our basic airway adjunct, our basic airway management. From there, this is our BLS stuff. This is bringing us up to the camera. So I would continue to breathe for him. Something like this, we call it an oropharyngeal airway. Slides in there, we can pull that tongue out of the way in here. What that does is actually just holds the tongue off of the back of the throat so we can get air in there. Still not a really good airway, but it helps us out just a little bit. They come in a bunch of different sizes. They come in a bunch of different colors. These are a couple of different ones here. We want to make sure that's the right size to get that in there. So this is a more than one person skill. So that is our basic airway management. When we have this, our airway in there, and we're breathing for him, and we've realized we want to put that tube in somebody's throat. I got somebody doing this once every 6 seconds while I'm getting my equipment ready. So we're going to leave that in there, pretend that somebody is breathing in there. If you've ever had surgery, you've ever seen an operating room, right, these are endotracheal tubes. So this is what that tube is that we put down your throat. Again, they come in a bunch of different sizes. We always say the average adult is about a 7.5 based on what's going on. The size of our patient, we'll pick the correct size equipment. Putting all that equipment together, we will lubricate those up. I don't put lubrication on this before it goes into our mannequin because it will never come out. So we'll pretend that equipment is there. We always have what we call a backup airway in case this doesn't work. This is a whole nother video that we can do. This is called a blind insertion airway device. This one just slides on in there, but we have that out there as well. We got something to inflate the balloon on our tube, and then this is going to be our video scope. There's two different components. This is the blade. The days before video scopes, this was all done manually. So I would actually have something very similar to this in a blade, and I would be right down in here looking in my patient's throat nice and close. One of the challenges that gets to be is you kind of have to line everything up to get that perfect view to see down into that mouth. With this, that alignment is less of a problem. Patients, if they had say a spinal cord injury, something you can't crank their head back, we can have some issues with some visualization. So this helps us a lot. This also comes in different sizes. First thing we're going to do, again, our AirTrack. This piece here is disposable. Actually comes with a little battery in it. We're going to turn it on. Turns on the little light that is in here. What that's actually doing is heating up the lens. That's part of that camera system to help it prevent it from fogging up. So we're going to turn that on, and what I'm going to do is call it loading my tube. So while that lens is heating up, this is the tube I decided I selected. This is called a stylet. Largely for video scopes, we don't use this. We use something different. This is called a bougie. Couple different, two different ends on it. I select the side I want based on kind of what my purpose is. I slide that in. It's much longer, much flexible. Actually allows me to get to some different places. This is where I would lube it up. And I'm going to actually slide it in. This is called a channeled track. So I'm loading this up. When I get done, this balloon is going to inflate in my patient's throat to kind of help seal that up there. So I would have tested my equipment first, right? Make sure that balloon is actually not going to pop when it's in there. So I want this all loaded up. This is going to be ready for me. And now here's my camera system. There's a little cover on here. I'm going to pop my camera system on there. And as soon as I connect it, it clicks, my camera turns on. So yeah, there's my AirTrack, should be fully charged for us, and I am ready to go. You can kind of see it in there. That's the video picture I get. So as you have mentioned before, my patient is still, I got somebody still helping me breathe with them. I'm gonna pull my oral airway out, and I'm gonna slowly make my way in here. So here's where I don't have to be right down on top of that patient anymore. So here's my video camera. What I want to do is actually not lose focus from what I'm seeing on my screen here, so I can see my patient's uvula, right? And I'm making my way down there, and I'm watching my camera as I'm going in here, and I'm getting a beautiful picture of my throat. So I can pull it up on my screen here. So this is what I'm actually seeing on the video screen here as I'm making my way in here. I see the uvula at the back of the throat. My tongue right at the top of the screen there, that little bitty piece of skin that's flapped right in the middle of your screen there, that's our epiglottis. So I want to kind of hit just behind that. This is the beautiful picture that I'm looking for the throat. So I have that bougie, I'm going to slide that in there. Right, so I can see that's where I want to go. There's the tube at the bottom of the screen there, that's our esophagus that goes into our stomach. I don't want to be there. So I'm going to slide that bougie in there, and now I have a beautiful track down into the airway. So from there, I'm actually going to take my endotracheal tube, I'm going to pop it out of that channel, and I'm going to feed it right on top of that bougie until I see that black line there cross underneath those vocal cords, and I'm now in the throat. So I'm going to hold that tube in there because I know it's in the right place. I'm going to inflate that balloon like I saw before. Pull my bougie out. I'm going to actually put one more piece of equipment on top of that tube. This actually helps us know that we're in the right place. I grabbed that bag valve mask that I had before, and now I see this beautiful chest rise and fall. So I know I am in the right, I confirm that I'm in the right place. I'm going to listen to my patient's lungs. I'm going to listen into their belly, make sure air is going into the right place. This is actually going to show up on my monitor so that I've got some, knowing that I'm catching some exhaled carbon dioxide. And I'm going to sit here and breathe in one every 6 to 8 seconds. I will continue to, this is a piece of equipment right here that is actually going to secure this tube in place for us. And then I'm in place. So that video scope, as you can kind of have seen, it helps us get some significantly better angles without being quite so close to my patient, and different perspectives on there than actually having to just get right up there and start cranking on that head and the neck and things that it can be a little bit more traumatic. That camera actually helps us out quite a bit. So that is our new tool. We're currently training on it. It should be out there by the end of this month.